I hope that I can do the Minister justice. He was very passionate about being here and deeply regrets that he had obligations at the World Health Economic Forum, which didn't allow him to attend. The Program Director, and I believe the Chair of APO, Minister of Telecommunications and Postal Services, who I believe will be joining us later, Honourable Minister Gwele, the Honourable Minister Dr. Aaron Motsoaledi, Deputy Minister of Health, Zambia, Director of Health, Swaziland, Dr. Makakula, Deputy Permanent Secretary of Namibia, Ms. Katjavina, Ms. Dr. Oliver Jacobi, or is it Minister? I apologize, Regional President of EMEA, Mr. Stephen Bowart, Managing Director of Orthotists, senior representatives of ministries and government representatives, expert presenters, distinguished ladies and gentlemen. It is my pleasure. Could I have my presentation, please? Apologies. And while we wait, just to correct, my title is Miss and not Doctor. Thank you. Thank you very much. What I would be focusing on today is enabling development through rehabilitation, and to share with you a perspective of the health sector in the government of South Africa. And as stated earlier, I will be presenting on behalf of Dr. Motsoaledi, who's the Honourable Minister of Health in South Africa. In addressing the contents of my presentation, we've got to state our problem. As government, we acknowledge that persons with disabilities and their families, as well as caregivers, remain the poorest among the poorest communities, and many continue to experience many barriers to even basic services. This being applicable in South Africa, but I would assume throughout many other African countries as well as developing countries. And in order to answer this question in terms of where we are at the moment and how we proceed to ensuring access or universal access to services, I would like to cover the following areas: informing the health reform agenda in South Africa, what are our mandates, the guiding principles, and why do we ensure a person that should be person-centered approach, realizing universal health coverage, and how do we do this? Through re-engineering of primary health care, the national health insurance, but also as a resource-constrained government, we cannot continue to have disabilities which we could be preventing. Hence, should we be not looking at prevention as a best buy? What are the recommendations and conclusions? Many of us are aware of the various global mandates. Perhaps the most obvious one that is relevant to us and for which we are extremely grateful looks at the SDGs. And while many people tend to focus primarily on Goal 3, we cannot achieve Goal 3, which looks at the health and well-being, without looking at other aspects, looking at disadvantaged communities, looking at poverty, looking at illiteracy. So it's very important when we start talking about the SDGs for us to be able to have comprehensive knowledge of how the various components of the SDGs will interplay. I think that what has been very pertinent is reference made in a by the prior speaker on Article 15. And as a recommendation, we need to see how this can be taken forward in terms of our region. But it is extremely encouraging and welcoming that member states of WHO are finally understanding that unless we have very firmly systems-based disability and rehabilitation services, it is impossible for us to have continuum of care. So why is it in South Africa we need to reform our health agenda? All of us are aware of the issues. We've had many communities remaining in abject poverty. We have inequalities in access to care, and this looks primarily at the huge division between those who can afford private care and those who can't. And at the moment in South Africa, more than 80% of our population are dependent on public services. South Africa is unique in that we have a quadruple burden of disease. Very often you go to conferences and people are talking about issues of single burden or double burden, but we have a quadruple burden of disease, and this is as a result of high burden due to HIV and AIDS and TB, maternal and child mortality, non-communicable diseases, as well as injury and trauma. And every one of those components of our quadruple burden of disease has a huge effect in terms of both persons with disabilities experiencing those quadruple burden of disease, but the quadruple burden of disease as well creating disabilities. We have a high proportion of aging population and a high impact of the social determinants of health. And in order for us to address reform broadly within South Africa, the government's work plan is positioned within a document called the National Development Plan. So what is the National Development Plan? The National Development Plan, right at the outset, talks of issues around reducing poverty and overcoming inequalities and inequities. And with regard to the health agenda, it is clear on creating affordable access to quality health care while promoting health and well-being, to reduce the burden of quadruple burden of disease, which I spoke to you now. Very important, right from the outset, from the highest level of mandate within government in South Africa, there is discussion and engagement and directives. How do we strengthen health systems? How does health system strengthening lead to universal health coverage? And very important in the NDP is the issue that health is far more than a medical issue, and that we can no longer see health and development in isolation of one another. And what is pertinent for us within the National Development Plan is a comment that disability must be integrated into all facets of planning, recognizing there is no one size fits all for South Africa, for people living in South Africa. So in terms of disability and rehabilitation, what are our national obligations? Firstly, we are very pleased to inform you that we have a framework and strategy for disability and rehabilitation in South Africa, and it looks at the provision of integrated, comprehensive, and appropriate disability and rehabilitation services. And what we have found in terms of both prior to the framework and afterwards were issues of integration. We cannot see disability and rehab sitting within an NCD cluster as we observe at WHO in Geneva headquarters. We have got to create a platform where disability and rehab services integrate with maternal child women's health, with HIV and AIDS, with TB, with primary health care, with hospital services. And what we envisage as a key outcome of implementing the framework is how do we use health systems to be able to deliver these appropriate care. South Africa is also very pleased to to have approved the white paper on the rights of persons with disabilities. And this essentially looks at how do all sectors within government and other stakeholders contribute toward disability inclusivity. And within the Department of Health, we have a guiding strategic document called the Annual Performance Plan. And it is you would hear very often that if you do not have targets and objectives around programs which appear in this document, no implementation takes place. We are extremely fortunate that in considering the political will in our country and the strategic will to be able to ensure that disability and rehab services fall within the continuum of care, we have, though I'm not sure if you can see that, but indicators around the implementation of services and looking at the proportion of health facilities that are accessible by persons with disability and number of districts with a multidisciplinary rehab team. And this is very, very important because I think that we have so many silos in all sectors within health. For far too long, disability and rehab was just seen as a vertical, non-priority program. There were silos in terms of how we offered rehabilitation, where individual rehab cadres would work in isolation. What we are envisaging moving forward is how do we now ensure that multidisciplinary teams work with respect and with joint outcomes for one another. So what are the principles that have informed this transition? And I say transition very sincerely. We are nowhere near where we would like to be. However, there has been progress. And what is informing the progress at the moment? Well, firstly, we have our population of persons with disabilities, irrespective of the cause, but a growing recognition that we have to understand the needs of persons with disabilities who experience the quadruple burden of disease. And I just want to alert you, while we look at maternal and child mortality, with improving health services, we have many more babies, for example, who require services due to some form of, there's no longer mortality related to poor health care. Babies are born, but they experience impairments and disabilities. So what is the key principles informing this transition have been the need to create equity. We have had so many components of facets of discrimination within the South African society, and equity is key. Firmly entrenched in the human rights approach, commencing with the UN Convention on the Rights of Persons with Disabilities, looking at continuum of care, ensuring that disability and rehab services are provided throughout the continuum, looking at promotive, preventive, curative, palliative care, and commencing and also looking at integration with other programs across levels of care and with other sectors. And very important to ensure the principle of people-centered is adhered to. And why do we need, within a South African context, to ensure that we respect and comply with the principle of person-centered approaches? The people of South Africa continue to experience the scars of apartheid. We have persons living in extremely rural, disadvantaged areas. Divisions created many years ago through the apartheid system. We have very, very high impact of the social determinants of health. We've got to ask ourselves, where do our people live? What do they eat? Can we tell our people to be healthy when the most expensive foods are the healthy ones? Can we tell our people to ensure that you exercise and be healthy when you have no safe places to do that? Can we ask, can you have a turning schedule for a person, a quadriplegic, who has no bed and sleeps on the floor of a shack in a township or an informal settlement? So unless we, both as health professionals, as technocrats, as bureaucrats, as politicians, as rehab professionals, understand the person and the context in which the person lives, we cannot ensure that you will have effective outcomes around rehabilitation. We continue to have, therefore, cycles of poverty which lead to ill health and ultimately poor development. And we cannot forget that while persons with disabilities experience a quadruple burden of disease, our quadruple burden of disease is resulting in disabilities. Our high burden of NCDs is resulting in stroke, amputations due to diabetes. These are issues that we cannot overcome. We have trauma and injury resulting in disability, TB resulting, ototoxic hearing loss due to TB. We have TB spine resulting in disability. So these are the issues that ensure that we as government, as from a political perspective, ensure that South Africa adopts a patient-centered approach. So how are we ensuring that disability and rehab is firmly entrenched and positioned within the Minister's endeavours to move towards universal health coverage? Firstly, we have the framework and strategy on disability and rehab, and my colleague Mr. Maluta Shavase, who heads the unit, is present, will perhaps be able to share more with you, and we can also make our framework available to you should you require. We have disability and rehab objectives now appearing in the policies and plans of other documents. And for the first time, we're seeing such objectives in, for example, the National Strategic Plan for HIV and AIDS. And all of us know for our services to be sustainable, we need to ensure that those objectives are in a place where there is a sense of accountability to implementation. We're also seeing it in the strategic plan for NCDs and a recently approved plan on adolescent health, among many. Disability and rehab is also now appearing within the whole primary healthcare re-engineering program. And these comprise three key pillars. One being the integrated school health program, where school children are being identified and referred when problems, impairments, disabilities are suspected. We are looking at the ward-based outreach team, and the ward-based outreach team is headed by a community health worker who then is the interface between the household and the first level of care, which is either a fixed or a mobile clinic. And then we have district specialist teams which have been aligned to the previous MDGs, and we are looking at how can we now utilize them optimally to also deliver on the present SDGs. And perhaps the most exciting thing, and for many of you are aware, is the developments and the progress around the national health insurance. So why is this so significant to health reform? The National Health Insurance is the conduit for universal health coverage to ensure that the whole population can access all health services on an equitable basis. And it's very important around standards. It serves as a standard improvement strategy to set down the minimum standards that all facilities must deliver. We've had pilots running and an acknowledgement that this process, due to the need for evidence, due to the need for resources, will be phased in. And we are preparing for the implementation of the first phase of the NHI. But the most encouraging and the most exciting news that we can share with you from South Africa is a directive from both the Minister and the Director General for Disability and Rehab Services to be fully inclusive of the delivery of national health insurance. And as I say, it's been identified as a priority. The components of rehabilitation to be integrated into the service benefits framework. And this is the key platform. Unless a point of service is not included, this service will not be delivered within the package of NHI. And that these services will be available, and at present it's fixed primary healthcare facilities. And initially, such services only cover prosthetists and orthotic services offered on an outreach basis at this level of care. But we expect that this is going to be expanded once the framework is developed for higher levels of care. But critical to this entire exciting process that we are presently involved in is the need for health system strengthening. And one of the issues that we have come across in terms of the 6 building blocks of WHO, and I'm not sure if we have colleagues from WHO, is a lot of uncertainty and lack of common understanding of what is this? Is this some kind of monster that WHO talks nobody can actually implement? And what we have found that for as long as we adopt this approach, we are able to ensure sustainable services. We ensure a responsive health service. So if, for example, we take the first building block of service delivery. Service delivery does not imply service delivery which occurs only in public service. Service delivery implies partnerships. It implies what services are available in public service, in private services. Service delivery implies donor-funded services. So all the services within this building block will contribute toward improved disability and rehab services. This allows us to move away from the vertical thinking around what is NCD health, what is HIV programs, what is TB programs. This creates the horizontal platforms whereby you can look at continuum of care, so that if, for example, I am the director for non-communicable diseases in the Department of Health, I will look at the prevention and control of non-communicable diseases, and this cannot take place until I ensure that disability and rehab is a continuum, is a key component in the comprehensive delivery of care. Department of Health to deliver on procurement of assistive devices, of medicines, of vaccines. And for as long as you have operational issue to procure assistive devices, we are ensuring that these processes are firmly entrenched in policy and strategy. And I would be very irresponsible representing the Minister of a developing country not to look at, and firstly, sorry, a disclaimer. I do understand that in many disability sectors, the word prevention is not respectful and not aligned to human rights. I refer and define prevention within a context of, can a resource-constrained country, and I believe that many of you present here today are from resource-constrained countries, can we afford to continue to allow the onset of disabilities, which could be prevention and control of non-communicable diseases, will prevent the stroke and will then prevent this person from ensuring extreme hardships, lack of development, as well as a dependence on the state. So the question here is, can we as resource-constrained countries also look at, should prevention be considered as a best buy in terms of cost effectiveness and health impacts? Moving towards my closure, what are the recommendations that South Africa is keen to address, and perhaps for consideration of other countries within the SADC region? We definitely need to improve the quality of the data that we have within the country in order for us to be comparable to other countries, both middle and high income countries. We need to improve surveillance to look at trends around disability and rehab. We now are observing a multiple increase in the demands for assistive devices among patients seen at clinics and facilities for treatment for HIV/AIDS, for example. We need to promote global tools to include morbidity as well as mortality. The mortality-morbidity debate is huge. In the NCD world, there are huge questions around why are we only measuring premature mortality. Many persons, for example, with NCDs, experience morbidity, and because the data is not collected, we have no idea on the demand for the services and the increasing trend in terms of birth. We need to ensure the disability and rehab components are mainstreamed within existing research projects. For example, if we are looking at issues around TB, we need to make sure that we are also looking at matters that relate to TB spine resulting in disability or ototoxic hearing loss. And one of the issues that we have considerable challenges with, international funders need to understand that if the funding mandate is HIV, there should be no reason why we exclude issues around disability and rehab, because in managing HIV, in managing NCDs, we've got to look at what are the components of disability and rehab. So the Transforming Health Agenda reflects transitions in disability and rehab service delivery. In South Africa, we have to do a lot more to ensure that the quality of lives of persons with disabilities and their families or caregivers is improved in order for them to access even basic services. South Africa believes we have many experiences for opportunities for sharing and learning with all of you, as well as our neighbors from the SADC region. And we have got to ask, could this Congress create outcomes for how we take realizing Article 15 forward? And perhaps that's a challenge for the discussions in terms of moving forward. And I think that if we do agree, it would mean that we need to work within a joint initiative with common objectives, common understanding, and respect for where we are in terms of development of services within the SADC region. Having concluded, thank you very much. I would like to just thank the Minister for allowing us the opportunity to share where we are in terms of moving towards development within the South African context and what initiatives are presently in place. Thank you.